right, let's talk about the ear. I think this is a topic that has just scared me off since medical school, but I think for me this helped tie some stuff together, so hopefully it does for you as well. So with normal hearing loss with age, presbycusis, you got to know what normal hearing loss is so that you can differentiate it from pathologic conditions. So classically, this is high frequency hearing loss, and they're not going to tell you that. They're going to tell you that the patient has trouble hearing people in a loud room, has trouble hearing screams and high pitched noises. And ringing in the ears is common and normal as we age and lose our hearing. So be aware of the difference between conductive hearing loss and sensorineural hearing loss. Conductive being solid structures in the external or middle ear, and then sensorineural being more so the nerves and stuff in the brain. Or medicine toxicity, I should mention that clearly. So the Weber and Rhine test. How annoying are these two things? It's like you learn it, you forget it, and it just never sticks with you. And I'm going to tell it to you, and I'm going to forget it tomorrow. So Weber test is the tuning fork that you put in the middle of the head, and normal, you probably remember, is hearing it equally in both ears. But if they have conductive hearing loss, they hear it louder in the affected ear. So remember that for a second. Somebody with sensorineural hearing loss is going to have reduced sound in the affected ear. So now we do the Rhine test, where we hold the tuning fork vibrating on the mastoid bone and then outside of the ear opening. And the normal thing here would be to hear air louder than bone. So let's say somebody has conductive hearing loss. Both things are going to be louder on the bone. So you got conductive hearing loss. We do the Weber test, and your left ear is just, it's way louder. But then we do the Rhine test, and we put the thing on the mastoid bone, and again, you think that's way louder than air conduction, which is abnormal. So two things that are abnormal in the same direction, more so touching the bone, suggests to you that it's a conductive hearing loss. The problem with the Rhine test, or this in general, is that it isn't helpful with sensorineural hearing loss. So let's say that we put the thing in the middle for the Weber test, and you hear it more so in the left ear, but then we do the Rhine test on that left ear, and air is louder than bone conduction, which is normal. So that would suggest to you that there's not conductive hearing loss in the left ear, and the Rhine test was normal. So this might tell you, Rhine test normal, Weber test negative, that in fact you had a lesion on the opposite side. So that's confusing, but in general, this is probably really only helpful for diagnosing conductive hearing loss. And somebody with sensorineural hearing loss is going to need audiometry, where we actually give different frequencies and diagnose their hearing loss. So this is just physical exam stuff, and I've never seen it done, to be honest with you. So these are some common causes of temporary hearing loss. So somebody who dove into a pool or was scuba diving may have a rupture of the tympanic membrane, and I think you should just be able to, they're going to give you a picture of it. There's going to be a hole in it, and it's obvious, but the treatment you should know is packing, and it heals on its own, so we don't need to do surgery. So just bear that in mind. They don't need antibiotics either, unless it was due to an infection, excuse me. So cerumen infection, probably going to get a picture of this as well. Somebody who just has you look in the ear and it's just full of goo, right? And that can cause hearing loss. And then serous otitis, which is really related to allergies, is just this dull fluid accumulation. And the key thing on exam for serous otitis would be a dull appearing tympanic membrane or a loss of the light reflex. And then labyrinthitis, which is inner ear infection, also called vestibular neuritis. We're going to talk about that again at the end here. But these people have acute hearing loss, and it usually returns later on, but it may take months. So otosclerosis, this is great. So this is a congenital problem, and it's related to basically just hardening of those bones where the stapes is, and essentially the stapes just hardens and stops moving, and if it doesn't move, then it can't transmit sound. And the key finding is bilateral conductive hearing loss, and if we go back to our Weber and Rhine test, I'm not sure how the hell we diagnose that, but the key that I'm trying to point out here is that on audiometry, they have a loss of low-frequency hearing. And this may not seem obvious by the way I'm saying it right now, but I think that this disorder, otosclerosis, is going to be presented to you, and it's going to look a lot like normal age-related hearing loss. But if you'll remember, With age-related hearing loss, you're going to lose high-frequency hearing. So somebody who can't hear loud noises like burps or farts that are, low-pitched sounds, that doesn't sound like normal age-related hearing loss. But the key thing that I think for you to know is what's normal aging and what is not. This is not, and it should suggest to you that it's otosclerosis. So be aware of this disease and don't miss it on the exam. All right. And then for Paget's disease, that's another thing that can present with hearing loss, and it maybe even be bilateral conductive or sensorineural hearing loss. But the key thing for Paget's disease, the only time you should pick Paget's disease on the exam for hearing loss is if there's an elevated alk phos level. All right, Cholesteatoma. This is just complete nonsense. This is on my exam. It's ridiculous. And this is really, if you think about like a keratin-filled cyst growing in the ear, that's what's happening here. And it's usually caused by something that happened inside the ear, like a ruptured tympanic membrane or infection that wasn't treated or trauma, surgery in the ear canal. Something aggravates those epithelial cells and they start kicking out keratin. And if this is left untreated, it can actually lead to osteomyelitis at the skull base or even a brain abscess. So it's not really a joke. You can't mess around with this. But patients usually complain of ear fullness. The hearing loss is conductive, at least at first, but it can progress to sensory neural hearing loss. And on my exam, the thing that really should have given this away, and I'm sure I missed it, is that they have foul-smelling ear drainage. Foul-smelling ear drainage. Take that home, memorize it. If you hear foul-smelling ear drainage in someone who has ear fullness, I would think it's cholesteatoma. And you have to treat this with surgery. All right? So, and I point out the foul-smelling ear drainage with cholesteatoma because I compared that, and I probably picked on my exam, Malignant Otitis externa, which is caused by Pseudomonas. This is on everyone's test. I think it was on my exam twice. Actually, you know what? I thought it was on my exam twice till I made this lecture and realized that it was on my exam once. And the other question was actually cholesteatoma. So good for me. The classic thing here is, again, an elderly diabetic patient, just like with the rhizopus infection, mucormycosis, it's going to be elderly diabetic patients. And the complication that we don't want to see happen here is osteomyelitis of the skull base because it can involve the cranial nerves, facial drooping, hearing loss, all that stuff. But the key thing they're going to give you is that there is granulation tissue, and this is always included in the question. Granulation tissue inside the ear canal, or if they show you a picture, something that looks beefy and red inside the ear canal, that should automatically lead you to think it's malignant otitis externa. Now, the other way they're going to trick you is you're going to think, okay, it's in the ear, so I'm going to give them eardrops. Well, no, you're not, because eardrops don't touch it because this disease is too big and bad to take normal eardrops. It's going to laugh at them, so you got to give them oral ciprofloxacin. I just wanted to mention Paget's disease of bone. You should have a history consistent with it, like bone pain or fractures. And again, if you are going to have this on your exam, it's going to tell you there's an elevated alkaline phosphatase, and that should be all you need to know about that. So, ototoxicity, I'm just putting on here so you're aware of, review the medicines that can cause it. With aminoglycosides, gentamicin the worst, and dosing these medicines once per day helps to reduce that toxicity, or you can measure the peak serum concentration, so be aware of that. And with all these different medicines, the hearing loss is going to be sensory neural. All right, vertigo. This is going to be on your test. So, what is vertigo? You need to know the definition because you'd be amazed how many of us don't know that. It's just the room spinning around you. You feel dizzy, and usually it's associated with moving the head or changing positions, rolling over in bed, laying down, and usually they have nausea and vomiting with it. Classically, now with any cause of vertigo, it's going to improve over time. The vestibular system will adapt and things will get better. The one exception to that is Meniere's disease, where you have chronic attacks. So when you're approaching a question that is describing vertigo to you, if you look at the duration of symptoms, that's going to help you figure out what the underlying cause is. So somebody who has vertigo, nausea for less than a minute and it gets better, that's going to be benign positional vertigo. Now, if it lasts hours or a few minutes, then it could be Meniere's disease. And Meniere's disease usually comes in attacks. The attacks can last as long as a day, but they may last only a few minutes. If it's something that comes on and resolves maybe in less than 10 minutes, then it could be a TIA, or vertebral-basilar insufficiency, where you just have transient loss of blood flow to the vestibular system. And if you have symptoms that last for a day or 2 or 3 days, then you think maybe this is an acute stroke. And again, even with an acute stroke, your vestibular system will adapt and the vertigo will go away. So that's not going to last forever. Or if you have vestibular neuritis, an acute infection or demyelination from MS, that's going to have symptoms for 2-3 days, followed by an improvement. And then just the general anatomy of vertigo, you got to keep in mind. Central vertigo is going to be a stroke, usually that can happen in the cerebellum or the brainstem, and I'll give you more details on that later. And then peripheral vertigo is going to be in our vestibular nerve or semicircular canals. So physical exam stuff that I think is potentially going to be useful for you. The head jerk test, or the vestibulo-ocular reflex. This is helpful if they give it to you because it can help you localize which vestibular nerve the lesion's on. So you take a patient by the head and you shake their head real fast, and their eyes should stay locked onto yours. If they don't, and then they correct rapidly back to your eyes, then you'd say the test is positive. So this is most useful if somebody has vestibular neuritis and you're trying to figure out which side it's on. So if I jerk your head to the left and there's a correction, the lesion is on the left side. So the lesion is always on the same side as the abnormality. The other thing that they may give you in the exam, and it should always be described to you because there's no videos on the exam, but is nystagmus. And somebody who has a vestibular lesion on one side is going to have horizontal nystagmus that is only in one direction. So if they tell you that somebody has horizontal nystagmus that changes directions, as in you have them look to the left and they have a beady nystagmus to the left, and then they look to the right and the nystagmus changes directions, that is a central or stroke sort of cause. Okay? So switching direction should make you think stroke. Staying in one direction should tell you that that's the opposite side of the lesion or nerve injury. Torsional nystagmus is specific for BPV, and I'll tell you about that in a minute when we get to that slide, like right here. So this disorder is extremely common. It's due to the loose otoliths in the semicircular canals, and these people have really acute onset of vertigo, but it only lasts for seconds. It doesn't last more than a minute, and they feel nauseous, they feel terrible, but again, it's super transient. In the office, you can take them by the head, lay them down, twist their head side to side. That's the Dick's Hall pipe maneuver, and that can help you elicit the symptoms. And when you do this Dick's Hall pipe maneuver, you want to look at their eyes, okay? And if their eyes are beating upward and rotationally, and they'll describe this to you on the test, then that is 100% pathognomonic for positional vertigo, okay? The other thing that strongly suggests positional vertigo is that if you do the maneuver more than once, is that the symptoms and the signs are reduced each time you do it. Okay? And the treatment is just home exercises, and you can give them meclizine for nausea until it gets better. But these people always get better, just may take some time. Meniere's disease. This is actually a nasty disease. I think my mom might have it. It's not fun. So you have two things going on here. You have a lesion, or not a lesion, excuse me, but you have vestibular symptoms and you have symptoms in the cochlea which cause hearing loss. So the vestibular symptoms will cause the vertigo, and classically these people have symptoms that come on in attacks, and they can last as long as a whole day. So if you picture someone who's had a history of just these randomly occurring several hour long episodes of vertigo that have happened infrequently over time, that should suggest to you that this is Meniere's disease. And the other thing is that they have usually, the vignette will tell you they have ear fullness. All right, that's not super specific for it, but ear fullness with vertigo that recurs over time and hearing loss, all that together strongly suggests Meniere's disease. And then what do we do for it? There's lifestyle interventions like the low-salt diet, things that can reduce the endolymphatic fluid. Avoiding caffeine and alcohol is recommended, actually. And then for treatment, I just don't think you're going to have to to do this, but you could give them something for nausea like meclizine, or even diuretics like furosemide. But again, I think mostly you're going to have to diagnose this, and if they tell you that the vertigo is lasting for more than a few seconds, you should automatically be suspicious. And if it's something that has happened for several years, and somebody who's otherwise young, between the ages of 20 and 40, very, very strongly would suggest that that's Meniere's disease. And the different causes of vertigo from a central or vascular standpoint, if you want to go for gold, you could know that a cerebellar infarct causes not only vertigo, but also difficulty swallowing, speaking, and double vision. And if it's a brainstem infarct, they lose sensation of the facial nerve and have a Horner syndrome. Again, that's probably more something for your neuro shelf, but if you want to go for gold, because the medicine shelf is notorious for having things that should not be on it, then you can learn that. And then I mentioned earlier that you could have a TIA sort of event where you have recurrent episodes of vertigo, maybe with another symptom like dysphagia or dysarthria that only lasts for a few minutes. That would suggest that in the patient with the right risk factors, like other risk factors for stroke, that maybe you're dealing with just transient ischemic attacks. Again, I mentioned this earlier, but nystagmus, looking in one direction and then changing direction, looking in the other direction, very, very suggestive of a central cause for the vertigo. And these people should have normal head jerk testing on both sides. All right, vestibular neuritis, this is just be able to say, I think it's easy to get this confused with, a TIA, or really get it confused with Meniere's disease. But the classic thing here is that you have an acute onset of symptoms with hearing loss, and if you have hearing loss, it's called labyrinthitis. No hearing loss is vestibular neuritis. They're the same thing, you just call it labyrinthitis if they have hearing loss. Sorry about that. And the key thing is acute symptoms, but they last for days, okay? And hopefully they give you that information. If not, it can be easy to get this confused with Meniere's disease. And they should have a positive head jerk test, and hopefully they give you that. They may not, but a positive head jerk test to the left or the right, but only on one side. The side that they're positive on is the side where the lesion is. And you should know the two different etiologies most likely. So if they don't have multiple sclerosis, it's a virus. If they have MS, it's MS. All right, and you treat viral vestibular neuritis with corticosteroids, and I thought that was important for you to know because that seemed very testable.